Just prior to developing our Jeopardy system, we had a 3-day-a-week surge availability, and that was largely at the discretion of the provider. So if the doctors felt they needed help, they could call for help, but that required approval of the manager. And there was a lot of ambiguity about when it was appropriate to call and when we shouldn't call. The surge system offers a standardized approach to flexible staffing so that we have assistance when we need it and we're not paying for a doctor when we don't need it. The standardized approach takes the ambiguity out of the equation so that doctors don't feel guilty calling when it's not clearly indicated, and they know when they need help. It is an early warning system so that we have assistance earlier rather than later. The first steps to designing a formal system was to develop a consensus around what kind of cap we should have. Our group previously worked on the basis of functional capacity. So if you felt you were too busy to handle the work safely, you were allowed and in fact encouraged to say no. But we had to change to a system of a numbers cap so that we could do some formulas and bring some standardization to when to call in. Our algorithm runs twice daily. So first at 7 a.m., which is the start of our day, we take a look at the total census to see how much help we need with rounding. And then we also take a look at our admitting capacity to see if we'll need help with admissions. We look at 7 a.m. and then we notify the physician by 7:30 a.m. if they need to come in. We take another look at 2 p.m. because that's about the time of day that our admissions tend to take off. Yes, the 2 p.m. huddle is a little more complicated because we need to predict what the admission volume will be for the afternoon. So we have a number of different methodologies that the physician can choose between. We have 3 different methods for trying to calculate the number of admissions that should arrive between 2 p.m. and 9 p.m. So in one method, you can look at the tracking board in the emergency room and count up the number of patients and divide by 2 or 3, and also try to anticipate the number of direct admissions. We have access to that data through our summary page. In the electronic medical record, we can see direct planned admissions, and then you would add that to the emergency admissions. If you're not so inclined to use a formula or something so complicated, the other approach is to just call down to the emergency room charge nurse and ask her how many folks she thinks might be coming in, he or she thinks might be coming in. Most physicians did elect to use the formula. We call in a surge doctor roughly 50% of the time, or just over 50% of the time. When we review our data, it looks like the surge assistance is indicated roughly 40% of the time, and the discrepancy there is due to handoff issues. So that we have physicians calling in for assistance because there's an additional handoff created when you have assistants admitting. The next day somebody needs to round on those patients, and who better than the physician who admitted them the day before. So sometimes docs are calling in the surge assistance when it's not indicated by the algorithm. One thing we noticed is that our admitting capacity varied from day to day, and we had some patient slots that weren't being used because not everybody admitted every day. So one team may have a census that was low enough to allow for some admissions, but because it wasn't their admitting day, they weren't allowed to do those admissions. So what we did to simplify the algorithm and increase admitting capacity was to change everybody to admit every day. Now we level load, and everybody admits every day. So if the census is low, it's truly low, and there truly is room for admissions. I think that physicians really appreciate the help, and there, on first blush, was some concern about the expense, but when we look at our length of stay has gone down since starting the surge system. So it's our belief that having the extra help available makes care more efficient, and our length of stay looks like it's decreasing. The expense is about 1.0 FTE. But that allows us to run an additional service, which would usually cost 2 FTE because we're 7 on, 7 off. Considering some sort of volume-sensitive staffing model has worked out really well for us.